When your kid has a fever, it's pretty worrying. But for a pediatrician, a fever that just refuses to go away, that's not just a symptom, it's a full-blown mystery. It's a signal the body is sending that something is wrong, and their job is to become a detective to figure out exactly what that signal means. So today, we're going to follow one of those detectives as they tackle a really tough case. So our story kicks off with a 4-year-old girl. She's been brought into the hospital because for 15 straight days, she's had this high fever that nobody can seem to figure out. The first guess? A really serious condition called Kawasaki disease. And we're not talking about a mild fever here. Her temperature is spiking up to 40 degrees Celsius. That's 104 degrees Fahrenheit. Every single day. For more than 2 weeks. You can just feel the clock ticking, and the pressure is on to get an answer fast. And that's the big question, right? When the obvious answers don't pan out. Where do you even begin? It means you have to be systematic. You have to follow every piece of evidence, listen to all the body's signals, and really embrace your inner medical detective. All right, so let's pop open the case file. The very first step in any investigation is just gathering all the initial facts and clues. So what do we know about our patient so far? Well, the first clues are kind of a mixed bag. You've got the long-running fever, symptoms like a sore throat, but check this out. The family history is a huge red flag. Her mom has 2 different autoimmune conditions. That tells the doctors right away they can't just be thinking about infections, they also have to consider inflammation and even genetics. The physical exam just adds more pieces to this puzzle. The strawberry tongue, the red eyes, a rash, swollen glands. These are all classic signs that definitely point toward that initial suspicion, Kawasaki disease. But are they telling the whole story? Or could they be symptoms of something else entirely? Okay, before we dive any deeper into the case, let's just take a quick step back. To solve this mystery, we really have to understand the main clue itself, the fever. What exactly is it? Here's the crucial thing to get. A fever isn't just your body accidentally getting too hot. It's a controlled, regulated response that's actually managed by a part of your brain called the hypothalamus. Think of it like your body's thermostat being intentionally turned up to help fight off whatever threat it's detected. It's an active defense. Not all long fevers are created equal. A fever of unknown origin, or FUO, which is what our patient has, is specifically a fever that lasts at least a week with no answer after all the initial tests. That's totally different from a recurrent fever, like a kid who just keeps catching one virus after another at daycare. And it's especially different from a periodic fever, which has this predictable, repeating pattern. This distinction is absolutely key. Okay, so with the case now officially classified as a fever of unknown origin, the real detective work begins. Doctors can't just take a wild guess. They need a systematic toolkit to hunt for the cause. The whole process is really built on 3 core pillars. First is the history, asking incredibly detailed questions to get the full story. Second, the physical exam, a thorough search for clues right there on the body. And third, the tests, gathering the hard evidence from blood work, cultures, and medical imaging. Now, you might think infections are the obvious culprit. And yeah, they are the prime suspect, causing up to half of all these cases. But that still leaves this huge chunk, almost 30% from inflammatory diseases, and another 10 to 15% from cancers that doctors have to consider. The possibilities are so broad, which is why the investigation has to be so meticulous. The testing itself is done in stages. They start with the basics: blood counts, urine tests, simple imaging. If that comes up empty, they move to level 2, digging deeper for more obscure infections or signs of autoimmune disease. And level 3? That's reserved for the toughest cases, involving more invasive procedures like genetic analysis or even bone marrow biopsies. So within that first level of testing, doctors are looking for these specific signals in the blood called biomarkers. These are really crucial early clues that help point the whole investigation in the right direction. 2 of the most important ones are CRP and procalcitonin, or PCT. Think of CRP as a general alarm for inflammation. It'll go up no matter what the cause is, whether it's an infection, an injury, or an autoimmune issue. But PCT is much more specific. It tends to shoot up during bacterial infections, but stays low during viral ones, which makes it a really powerful tool for telling them apart. What's really cool is they operate on different timelines too. PCT is like the first responder, rising within just a few hours of a bacterial infection. CRP is a bit slower to react. In our patient's case, both were probably very high, confirming there was massive inflammation. But the fact that the PCT wasn't sky-high might have been an early hint that a classic bacterial infection wasn't the real problem here, which only made things more mysterious. And here's a critical rule of thumb that guides every pediatrician's thinking. The longer a fever drags on, the less likely it is to be a simple infection, and the more likely it is to be something more complex, like an inflammatory disease. For our patient, at day 15, the odds were definitely shifting away from a simple bug. So, armed with all this knowledge, let's get back to our 4-year-old patient. The team had the physical clues, they had the initial lab results, but the big break in the case? It came from going all the way back to that very first pillar of the investigation.
This was the game changer. During a more detailed history taking, the doctors discovered this wasn't just a single 15-day event. For the last 2 years, this little girl had been having these episodes of fever that lasted about a week, happening almost every single month. They'd just been dismissed as separate infections, but now a clear pattern was emerging.
And when they looked closer at the symptoms that came along with these regular fevers, a classic pattern just jumped out. Periodic fever, aphthostomatitis, which are mouth sores, pharyngitis, a sore throat, and adenitis, those swollen neck glands. This wasn't just a random collection of symptoms, it was a specific syndrome with a very memorable acronym, PFAPA.
The diagnosis was PFAP syndrome. It's actually one of the most common periodic fever syndromes in kids. It's not an infection, it's an autoinflammatory condition, which basically means the body's own immune system is just activating on its own and causing all this inflammation without any external trigger, like a virus. The symptoms our patient had, they were a perfect match.
And the response to the treatment confirmed everything. When she was admitted, they gave her antibiotics, but the fever didn't budge because it wasn't a bacterial infection. But the moment PFAPA was suspected and she got a dose of steroids to calm all that inflammation, the fever just vanished. The turnaround was so sudden and so dramatic. So what can we learn from this incredible piece of medical detective work? This case really highlights a few key ideas when you're tackling a complicated problem like a fever of unknown origin.
I think the most important lesson here is that a thorough history is absolutely everything. The clue that cracked this entire case wasn't in a blood test or an X-ray. It was hidden in the patient's story, just waiting to be uncovered. It's a powerful reminder that fever isn't the disease itself, but a message. And the real challenge for doctors and for parents is to listen carefully enough to understand what the body is trying to say.